Hi, everyone. Thank you for joining today. My name is Molly Whitt. I'm a second year psychiatry resident with the UNM Psychiatry Department. I'm going to go ahead and start sharing my screen. Always the most exciting part. And then get this into PowerPoint mode. Okay. So hopefully you can see this. Awesome. Thanks for that thumbs up. Okay, so I'll be talking today about best practices for working with transgender and gender non-conforming patients. If you have any questions during the seminar, feel free to unmute and ask. Otherwise, we should have a good amount of time after the seminar to answer questions. And I would definitely encourage questions for this topic, because I know it's kind of one of those topics that can get confusing. So without further ado, my name is Molly Whitt. Like I said, I work for the UNM Department of Psychiatry as a second year resident. I don't have any financial disclosures to make related to this activity. Disclaimer, the views in this presentation are reflective of me. Oh, and great, there's a Google link to the PowerPoint. I did adjust some slides from that PowerPoint to include some examples, but otherwise it's the same presentation. If you want to follow along, feel free. The disclaimer, yeah, these are my views and what I have learned in my education. They don't necessarily represent the University of New Mexico. Let's see, learning objectives for this seminar. We're going to define and describe gender identity, gender assigned at birth, sexual orientation, and gender expression. We'll specify the DSM-5 criteria for gender dysphoria and disorders of development, disorders of sexual development, and analyze some challenges and controversies associated with these diagnoses. And then at the end, we're going to summarize best practices for engagement with and treatment of transgender and gender nonconforming patients. So some cultural considerations that we usually start off with. First of all, I am cisgender, female, and heterosexual. So I am not a part of the transgender community. And I have worked closely with this community. However, I think it's important to recognize that I am not part of it. I do have some very close friends who are part of it, but I don't claim to be part of the community. However, that being said, I think it's important for us to be able to educate ourselves regardless of whether we're part of a community or not. And it's kind of been one of my goals to be able to not only educate myself, but help with the job of educating others. Since I am cisgender, female, heterosexual, I'm part of this minority, or the majority group. Therefore, I highly recommend or would encourage people to ask me questions about this, and I'll answer it to the best of my ability. And also, hopefully that will take away some concern about, like, hurting, embarrassing yourself or offending anyone, because I won't get offended if you have questions about this. Another consideration, a lot of these standards of care are changing, and we're kind of keeping up as much as possible with when our fellow folks are telling us how, like, the best way it is to treat patients. So this does represent our current ideas and standard of care. However, be aware that things are changing as we're becoming more and more culturally aware. This toolkit and the slides that I have put together, it's one view of how to work with transgender and gender nonconforming patients. There are other views out there. This in particular is what the American Psychiatric Association has also published. So this is kind of going off of that organization's recommendations. Epidemiology, it's really difficult to determine the prevalence of transgender and gender nonconforming patients. There's variations in categories used by researchers, variations in ways in which individuals themselves identify themselves. There's difficulty with sampling methods, and there's still a very understandable discomfort in revealing identity to researchers. And so this is kind of an ongoing quest to try to best describe epidemiologically this population. Current estimations put it around 0.6% of US population 18 years and older identify as transgender. That would make it about 1.4 million individuals. I and kind of experts on this matter do think this is a likely an underestimation, and to the point, the extent of which it's an underestimation is difficult to know. But really, you will, or you likely already have, if you're a clinician, you will treat a transgender or a gender nonconforming patient at some point. So this is just kind of a reminder of some of the best practices. So first of all, what is gender? We hear about, gender being a construct, and really what we use the word gender to describe is this whole sort of set of aspects about a person. I have this little cartoon here, but I really like how it highlights each aspect of this. You have your identity, there's expression, which is what the outside looks like, attraction, and then sex, also called gender assigned at birth. So we'll go ahead and just look at each of these components. Identity, that is how a person internally feels they are. This is how they identify themselves when they close their eyes. Do they feel like a man? Do they feel like a woman? Do they feel like something entirely different? Do they feel like neither a man nor a woman, or perhaps a third gender, third option? Maybe, and we've started splitting the idea of kind of womanness and manness from the same spectrum. It's no longer one or the other. Maybe they're a little bit of both, or more one than another. So someone's identity can be really as diverse as the number of people in a room. Some qualifiers that will go along with identity are maybe transgender. So someone will say, I'm a trans male, and I identify as male. They might be cisgender, which means the gender that I was born and said and called at birth is what I still consider myself to be. They might be gender queer, which is kind of none of the above. They might be gender nonconforming, which says, I don't even agree with the whole idea at all, and I, kind of identify as something different. If you hear of someone identifying themselves with a term that you're unfamiliar with, it's completely appropriate to just ask them what that means to them, and especially because terms like genderqueer and gender nonconforming can mean different things to different people. Gender expression, generally conveyed through appearance, behavior, and personality styles. This is something that you can tell by looking at someone. It's culturally masculine or feminine, and that's still the most common expressions that you'll see are masculine and feminine. Can also be androgynous, so someone trying not to appear one gender or another. And it can be a combination of masculinity and femininity. One of my favorite examples is one of the cast of Queer Eye on Netflix, Jonathan, who has just the most beautiful hair and beard and wears the most gorgeous skirts. And that is an expression that includes both femininity and masculinity. So that is what gender expression is. Sex is also called anatomical sex. This is something you cannot tell by looking at someone. Usually these are biological indicators. These are based on internal and external genitalia, as long as they are non-ambiguous. Also has to do with sex hormones, sex chromosomes, and gonads. Are you XX, XY, or one of the other kind of combinations, XXX, XXY, things like that. That would be what we would refer to as sex. Gender assigned at birth. In the DSM-5, they refer to it as natal gender. This is your initial gender assignment. The doctor looked at you when you popped out and looked at your bits and said, it's a blank. So this is, you're usually assigned either male or female at birth. If there's ambiguous genitalia, the practice for a long time was to basically to decide what the genitals looked closest to and assign that gender, or have the parents or doctors decide. Gender assigned at birth is another thing you cannot necessarily tell by looking at someone. Most often, the greatest like the most common is that you can tell by looking at someone what their gender assigned at birth is. But I think it's important to remember you might not necessarily be able to tell that someone identifies as transgender just by looking at them. And then orientation. Orientation doesn't actually have anything to do with what you think of yourself or how you feel about yourself or how you view yourself. And it has everything to do with the kind of person or people that you are attracted to. So you can be sexually attracted to women and or men or both. And we have different words for each of those. Heterosexual, generally you're attracted to the opposite gender. That is by far the most common, but we also have homosexual, which is people are attracted to someone of the same gender. Gay and lesbian can be referred to as either males attracted to males, females attracted to females, or just used as a term of identity regardless. Bisexual is generally you're attracted to both genders. Pansexual can refer to you're attracted to many different genders or anything on the gender spectrum. And then asexual is that you don't feel particularly attracted to any gender, and maybe you don't feel sexual or romantic attraction to anyone. And these are all just ways that people do identify and typically label themselves. And so it's just a way of kind of people describing who they are to you. So this is all of those listed out. I already kind of said all of these, so we'll head on to the next slide. And this is somewhere where we could practice. I usually use this time to say what I can identify myself in all of these parts. And I would challenge you, regardless of who you are, how you identify, to go ahead and you are able to list all of these things about yourself as well. So my identity, I identify as a female, and I have long hair. I look pretty feminine most days, and sometimes I can be a little bit more masculine, but generally I identify as a female and present as a female. My gender assigned at birth, it was female, and so I would consider myself a cisgender female because I agree with what the doctor said when I popped out. They said I was a girl, and I totally agree that I am a girl. My sex, as far as I know, is female, and my orientation is straight. So it's between straight and sometimes kind of ace, because attraction will kind of come and go. So like I said, even if you don't feel like you're a part of a certain group, you're still able to list all of these things about yourself. And I think I always really encourage people to be aware of what they think of themselves. And this kind of helps us avoid the whole sort of normal trap of like, well, I'm normal, so everyone else must be different. And in reality, they're all descriptors. So we're all able to use, we're all one or the other or various parts of these at some point. So I do encourage people to practice this, practice thinking about yourself in this way. So what is gender nonconformity versus gender dysphoria? Gender nonconformity, you might say you're a gender nonconforming person. I got a little ding. Do I need to do anything about that? Okay. Thank you. I appreciate it. Gender nonconformity is it's a description. This is the amount to which a person's identity, their role, or their expression, like we were talking about, it's the amount to which it differs from cultural norms, maybe norms attributed to their gender or norms attributed to any gender. So you can say that they're gender nonconforming. That's quite different from gender dysphoria, which is a diagnosis. Gender dysphoria refers to the discomfort or distress caused by a discrepancy between one's gender identity, so what they feel like they are themselves, and their sex assigned at birth. So what the doctors said when they popped out, they said, "Oh, this is a boy," and as that individual went along, they felt more and more like, I'm actually a girl. Sometimes that can cause distress, and that distress, once if you're seeking treatment for that kind of distress, would be billed as gender dysphoria, and diagnosed as gender dysphoria. Gender dysphoria, to some extent, does suggest treatment because it is a diagnostic. Has criteria. So gender dysphoria, it's been in the DSM since DSM-2 in the 60s. At that point, it was called transvestism, and it was in the sexual deviations category. Since then, it has essentially changed with every iteration of the DSM. It's gone from transsexualism to gender identity disorder, and sexual and gender identity disorders. It's been under several different categories. And this most recent is the parent category of gender dysphoria and a diagnosis of gender dysphoria in adolescents or adults. So we're moving away from a gender identity disorder because individuals said, well, I don't have any disorder in my identity. I know what I am, but it's not matching all of my paperwork. So that is what's causing me kind of distress. So it was like, well, then if this is causing you distress, then it is a dysphoria. We'll talk about whether that's appropriate or not, but that's how we went from gender identity disorder to dysphoria. The idea that people do know what their identity is, that's not necessarily giving them issues. So what is the criteria for gender dysphoria? This is in the DSM-5. I highly recommend reading that section if it's something you're interested in, to at least know where our field is currently. This is the criteria for adolescents and adults. There's also criteria for children, which I won't go into in this slide or in this presentation. But it's a marked incongruence between one's experienced and expressed gender, or assigned gender, of at least 6 months duration and manifested by at least 2 of the following, good old DSM. It's either a marked incongruence between expressed gender and primary and secondary characteristics, or there's a strong desire to be rid of primary and secondary characteristics because of an incongruence. There's a strong desire for the primary or secondary sex characteristics of a different gender, or a strong desire to be of a different gender, a strong desire to be treated as a different gender, and then finally, a strong conviction that one has the typical feelings and reactions of the other gender or some alternative gender. So things that I do like to bring up is that this only requires 6 months of duration. So this is not something where you have to ask someone, well, when was the first time you felt this? Was it in childhood? Has it persisted this whole time? It's not uncommon for people to be in their kind of later phases of life, be it young adulthood or middle adulthood, and never even having asked themselves what they felt like their gender is. And then what I've heard from friends of mine who went through this at a later age was that it kind of made all the pieces fall into place. Like, no, they'd never necessarily, they don't remember thinking that they were a girl after people had called them a boy when they were younger. But in their 30s, they realized that just kind of, it made a lot of things make sense. So this can happen even at any phase of life. And it would be, you would want it to be at least 6 months duration. And let's see, other things I usually talk about on this slide are you can kind of differentiate something like a young girl who dresses as a boy, like being a tomboy, because they typically are, still feel like they're a girl, but don't necessarily want to be in the gender roles of what that is. Gender dysphoria does have some specifiers. It can be with a disorder of sexual development, or it could be post-transition. Oftentimes, post-transition is used to as like a stable or not active specifier to indicate that someone is no longer in active dysphoria. Typical onset of behaviors for gender identification are between 2 and 4 years old. So this does start fairly young. If a child has dysphoria, typically increases as they approach and anticipate puberty. You can imagine if a young person identifies as a boy, and then they hear that they'll be developing breasts, that can cause considerable concern for them. The rate of persistence really varies on the study. It can range from 2.2% in some studies to 3%, to 30%. And that's in studies in males, or 12% to 50% in males. This really just reflects the amount of difficulty that is had in studying this population. So hopefully that's something that might be understood a little bit better in the future. Differential diagnosis for gender dysphoria. Again, this is straight from DSM. But it would be a nonconformity to gender roles. So again, the tomboy that we were talking about earlier, she might feel like she's a girl, but like wearing cowboy boots and like wearing jeans and like doing all the boy things, but still feels like she is a girl. She just doesn't necessarily want to do what is seen as girl activities. Transvestic disorder. There's some pushback in calling this a disorder, but it's still in the DSM. And this is the behavior of generally males, sometimes females, of dressing in the opposite gender. So you could think of a drag queen in order to fulfill sexual roles. It's a disorder if it becomes an issue, but there's been a lot of people in the kink community, especially, who are pushing back and saying this shouldn't be in the psychiatric diagnosis manual. But transvestic disorder is identifying as male, dressing as female for other purposes, or the opposite. Body dysmorphic disorder. So that is something that you want to identify. Are they having body dysmorphic disorder versus gender dysphoria? Body dysmorphic disorder is more about specific elements of someone's body. So you feel like your nose is just, just never looks right or looks good. You feel like it's always giant. You might end up having a lot of surgeries to correct things that are really within a normal range. Schizophrenia, other psychotic disorders, is listed under differential diagnoses. The biggest difference here is that this is the expression of being transgender is going to persist regardless of psychosis. So while if someone is having a psychotic episode versus if they're not having a psychotic episode, their internal identity as of a gender should not necessarily change. So disorders of sexual development We won't go deeply into that, but they are not psychiatric disorders. These are ranges of congenital conditions, which are associated with development of internal and external genital structures. So that's essentially if a child is born with ambiguous genitalia, perhaps they have streak ovaries, perhaps they have underdeveloped testes or testicular agenesis, they would be diagnosed with a disorder of sexual development. This can include people who identify as intersex. So the identity that goes along with having ambiguous genitalia or being sort of in between the gender dichotomy that we have now is intersex. So these folks might identify as intersex and they say that they are androgynous and in between genders, or they can identify as one of the more common genders like male or female. So there's a pretty wide variety here. Disorders of sexual development do not necessarily indicate that someone is going to be transgender later on or be gender nonconforming. There's no particular there's no similarity there, since this is since expression is more of and identity is more of an internal and emotional component. So there is a discussion on diversity versus pathology. So the World Professional Association of Transgender Health, called WPATH, they did release a statement in 2010 urging the depathologization of gender nonconformity. And they said that the expression of gender characteristics, including identity, that are not stereotypically associated with assigned gender, is a common and culturally diverse human phenomenon that should not be judged as inherently pathological or negative. There has been a lot of pushback with the use of gender dysphoria because typically the dysphoria comes from people feeling like they are seen as one way and treated as another. And that's more of a dysphoria in how they are perceiving the world and how the world is perceiving them. Not necessarily a dysphoria like we might think of like depression. So there's been some pushback about this is more of a gender non-congruence, incongruence, and people shouldn't have to be dysphoric in order to get treatment for something that is considered culturally diverse. So that's part of the ongoing discussion about whether this should be a DSM diagnosis. Perhaps it should be an endocrine diagnosis. And kind of where would folks lie if we were able to, as a culture, treat folks like this with total respect? Would there necessarily be a dysphoria associated? Comorbidities with in the transgender and gender nonconforming community in literature reviews indicate much higher instances of depression, suicidal ideation, anxiety, substance abuse, eating disorders, and dissociative disorders. The highest vulnerability is in adolescent years. And it's notable that risk is significantly reduced with gender affirming care. So that's kind of the crux of all of this, is if we can reduce this risk by simply affirming someone's gender identity, it's a really cheap and effective way of reducing someone's medical risk for some pretty dangerous diagnoses. So best practices. Gender affirming therapy is kind of the umbrella term for some of these best practices. This is a therapeutic stance that focuses on affirming a patient's gender identity rather than trying to repair it. So if a young man comes to you and says, I am a female and I identify as a woman, it's not like, well, are you sure? Have you tried other things? You know, like, do you really think that's true? Is it because you were abused as a child? It's not really focusing on anything like that. It's just focusing on affirming that patient's gender identity. Like, okay, you were born as a male, you identify as a female. How can we best support that? Best practices. First and foremost is pronouns. Most people have heard at this point something about preferred pronouns, and it's simply using people's pronouns as they request them to be used. These can be she, her, hers, he, him, his, they, them, theirs, or some of the more androgynous ze, them, zers, ze, sir, sirs. So it is appropriate to ask if you're uncertain, and completely appropriate to offer your own as well. I go by she, her. If you make a mistake and are corrected, you can apologize and thank the person for the correction and continue on with the conversation. Oftentimes I think people get flustered, and there's no reason to get like uncomfortable or flustered. You can just kind of move on and try to get their pronouns correct the next time. It can certainly be difficult if someone's expression is variable from what their identity is, but I think with practice, you're able to kind of start peeling, divorcing expression from pronouns pretty easily. Record keeping. So this is something if you're in any kind of practice or in a position in which you're able to influence how your EMR is set up. It's good to be able to have a designated place, and it's recommended to have a designated place in your notes or in your electronic medical record to document current gender identity and assign sex at birth, because you will have to do maintenance health maintenance based on that. Sometimes people use that as a sex or GU or administrative gender. And then also a place to record pronouns or preferred name. This is especially helpful if you have a patient who's going to be a returning patient. You don't want them to have to specify their current gender identity and their preferred pronouns and their preferred name every time they come to the clinic. Best to just be able to have that in their records, and then after that initial visit, refer to them by their preferred name and their preferred pronouns from there on. That includes staff training. So all staff comfortable providing gender affirming care, including pronouns and preferred names. That's front staff, MAs and techs, providers. Anyone who's going to be providing any kind of face-to-face time with patients should be comfortable using preferred pronouns. Other things that I like to encourage and I consider in best practices are some visual cues. These are things like gender affirming language on signs or forms, areas where you don't have to just check male or female, either having an other or having a couple of other options there. And then I myself have just a sticker on my badge that has my pronouns. It's something that not many, if people don't know what it is, they don't necessarily notice it, but people who have had trauma in this area, if they notice your stated pronouns, it is a bit of like a kind of a signal that you do have some amount of gender understanding. So visual cues are really helpful in someone kind of understanding what kind of place they're at. So best practices, I think there's like a good range of people on this talk. So we'll just chat about some of these. Outpatient the record keeping changes, as I mentioned, and then trying to have some supportive group therapy available that is gender specific. If you have gender specific therapies, someone who is transgender should be placed in the gender in which they identify. And then all staff be trained, as said before. Inpatient, transgender or gender nonconforming patients should be in gender appropriate rooms, and that would be the gender with which they identify. I've also seen single occupancy rooms if available, and that's a good option as well. One thing, if you're an inpatient provider, please don't stop cross-gender hormones on admission. This is something I have seen a lot because people say, well, we just don't know what's causing what. I understand that. If possible, keep those hormones going because it can just cause more dysphoria later on. And just consider stopping other things before those hormones. Other times, people just don't restart them because they don't understand like the dosing or giving hormones. Totally appropriate just to keep that person's current hormones on board. In the emergency department, the biggest thing I've heard from folks in this community is just focus on the issue that brought the patient in. If it's heart, if it's chest pain or things like that, or shortness of breath, might not necessarily require going deep into their gender preferences. So focus on what brought the patient in and be aware of the questions that you're asking and why. A big thing that providers can do is provide letters of support if you have a transgender patient. I placed one here that is an example that was provided by the APA, and this was for gender marker change. Common letter reasons are for surgery or gender marker change. Marker changes are typically on a passport, birth certificate, or driver's license. And it's just small things that can make a person feel like they're living as they in the gender that they identify with. It is important to consider a patient's capacity when writing these, but if it gets to the point of they're not capable of making certain decisions, that's kind of like, that is something that you should take note of. Typically, these patients are capable of making these decisions. Simply want their material to reflect how they want to exist in the world. So with that, we have gotten to the end of my material. We did define and describe gender identity and gender assigned at birth, sex and sexual orientation, and gender expression. Hopefully folks will be able to practice on themselves. We specify DSM-5 criteria for gender dysphoria and disorders of sexual development, which is not, in fact, a psychiatric diagnosis. We looked at some of the challenges and controversies associated with this and summarized some of the best practices for engagement with treatment for transgender and gender nonconforming patients. These are some resources. I was able to do some QR codes. Hopefully those show up if you're interested. The Do Ask, Do Tell toolkit has some great information for both providers and staff in various environments. It's very accessible and well put together. The World Professional Association of Transgender Health has a lengthy document on best practices, so that is available there for free. And then the APA guide to working with transgender and gender nonconforming patients is actually excellent as well, and there's a link to that if you find yourself wanting more information or wanting to get some of this information back on board. So with that, I am happy to answer questions. this is a perfect time to ask that question that you never wanted to offend someone with, but we're always kind of wondering. And yeah, that's what I have. Someone can share their identities. Awesome. We have a group of competent providers. It's great. Okay, so we got a question in the chat. How do you go about talking to a staff member who does not use the correct pronouns for transgender or gender nonconforming individuals? I think so. I would be a bit curious about why they don't use the correct pronouns. And that might be something to ask. Like, this person has indicated that they use she, her, and I notice you use he, him. Is there a reason for that? That's a little bit confrontational, but also just kind of gentle reminders. I have been corrected and reminded other people that someone prefers to go by they, them pronouns. And so just making a habit of reminding each other that this person prefers these pronouns. Other things you could do are things like making, if you have a policy or if the clinic has a policy, just reminding people of, in this clinic we do use good, correct pronouns for individuals. You're welcome. Thanks for the question. I hope that was helpful. This is a difficult topic because it has become very politically charged. And so people will, maybe not respect someone for their own political purposes, and just reminding them that we are providers and that's maybe we shouldn't have that kind of behavior in the clinic is best. Anyone else? Anything that people were a little bit confused about that maybe I went through too quickly? Okay, Angela had a good question. What do you recommend is the best way to show support and advocacy if you're not part of the community? I think one of the best ways to show support is to accept people as they express themselves. And that includes things like, not necessarily being like, hey, you were dressed like a man yesterday. What's the deal? Being open to really however someone feels like expressing themselves that day. Other ways to show support, if you know of legislation happening, things like that, be sure to, you can kind of write or contact your legislators and say like, hey, this is something that I'm concerned about because of the folks in this community. I really try to have people like ask me questions that might be, they might not want to ask someone who is trans, um, because I have worked enough with folks to be able to say like, um, this might be the best way to to ally with them. That being said, I don't want to speak for the community, but I do think it's important that they are not the only ones speaking. So Caitlin says at Northern VA Mental Health Institute, some of us will wear shirts and have stickers on our badge or signs on our doors so our patients know that we're allies. Yes, that's great. And at a VA, that's good to hear. Yeah, I have several stickers or pins and things like that. I did have some folks at one point, some older patients who were like, "Why do you have she, her, hers on your badge? What does that mean?" And got to say like, "Well, this is just to indicate what my pronouns are." So sometimes you might even have, that might be a conversation starter for normalizing talking about pronouns or talking about gender.
Molly, if you scroll up, Grace had another question. She says, what is the difference between non-binary and gender non-conforming?
Um, to my knowledge, they're kind of the two different names for the same idea. Yeah, non-binary and gender non-conforming. If you hear a person say that they're one and not the other, it might be worthwhile to ask them a little bit more about that. But non-binary and gender non-conforming are kind of getting to the same idea, which is that I don't identify as either male or female. Thanks for that question. And thank you, Angela, for pointing it out. I'm curious, where all are some of the folks from? Do we have someone from Northern VA or Northern? Yeah. Are you Northern Virginia or are you a VA? Sorry. Northern Virginia. Wow, cool. Church.
And while you guys are
This is awesome.
in the chat where you guys are from, I just want to do a little bit of an introduction. I'm Angela Bex-Harris. I'm the operations specialist for our rural psychiatry program. This is a rural psychiatry series that we're doing that's going to be happening every month. Molly has graciously been told that this is going to be our first presentation of our semester and our year. So thank you so much, Molly, for getting us off to an amazing start, and hopefully for things to come. I also want to know, if you guys have not signed up for our listserv, please do so. That's where you will find out where the other presentations for each month will be, when they will be occurring as well. And I also don't want to leave out, I'm going to turn this over to Alex so that he can tell you how you are to obtain your CEs for this presentation. I also want to give a heads up that perhaps in the in the near future, hopefully, if not for our next one, then the third presentation, we will also be offering CMEs. So if you know anyone who would be interested in that, this will be a great way to get people in that will be offering CMEs within the next presentation or two.
Awesome. Well, I had no idea people were going to be from this far, this far away and abroad. The exotic Northern Virginia. Very exciting. Well, thank you guys. Thank you so much, Angela and Alex, for putting this on and for making this all happen. Awesome.
No, ma'am. Thank you, Miss Molly. We totally appreciate you. I appreciate you. Let me just also give you a little bit of heads up about the CEs. You have your link in the, Alex put the link in the chat box. You can utilize the link. There's also a QR code as well that you can just click on, and it'll take you to the evaluation. You have 48 hours from today to complete the evaluation. As soon as you complete the evaluation and hit the submit button, your certificate would automatically populate. All right, so take a screenshot of that or save that. If you want your certificate to be emailed to you, right at the bottom of your certificate that populates, it asks you for your email address again. If you re-enter your email address, it will send you an email version of your certificate. So again, that's 48 hours for your CEs before the link expires, and you will automatically get your certificate at the end. Again, I want to say thank you to Molly. We totally appreciate you. This was great. This was informative. I hope you come back and do a part 2 to this. We truly appreciated you for taking the time out and spending this today. I want to thank the audience as well. You guys have been great and amazing. Thank you for all of your questions. And just one more shout out to Alex, who has been doing his tech support in the back. So thank you, Alex. I totally appreciate you for that as well.
No, thank you both. That was great. Thank
you. Yeah, thanks everyone for attending. Okay. Angela, should we keep the link up for folks until 12?
No, ma'am, we don't have to. If you have your link, if you have already, or your QR code, you guys are good to go. Again, thank you guys for participating, and we hope to see you about this time next month for our second presentation in the series.
Yes, and thanks so much.